All right. Well, welcome everyone. I am Chris Fortman. I'm the CEO of the Minneapolis Heart Institute Foundation, and we are here kicking off our spring summer series of On the Pulse. So, thanks for making time to be here with us. I just have to start by giving a little background. I know many of you know us, but for those of you who are getting to know MHIF for the first time, welcome. We are a nonprofit organization with the vision of a world without heart and vascular disease. And we deliver on that vision through our mission, which is to improve cardiovascular health through innovative research and education. So, this visual just gives you an idea of the partnerships, of the priorities, and that we're an independent nonprofit organization that is committed to doing the research and education that supports our physicians and, in the end, improves the quality of life for our patients. So here's just a little snapshot of research and education, the two key components of our mission. We have over 200 active studies touching the lives of over 2,000 patients. We're thrilled to have research going on in all subspecialties of cardiovascular health. And also, none of the research would happen if we didn't have the people interested and informed to do it. So, education is a key component. We have a wonderful internship program. We do grand rounds every Monday here at the foundation and offer CME. And all of our research needs to get out to the nation, to the globe. And so we have published over 200 peer reviewed manuscripts just in the past year. So here are just some pictures because pictures really tell it all. Because of the expertise we have here at the hospital, at the clinic, and in the foundation, we are sought after for first in world and first in human clinical trials. We find our inspiration in the stories of our patients. And as I mentioned, we're committed to sharing the findings of our research, many of which end up changing international protocol and touching the lives of people across the world. So this is really made possible, and I know I have some of our donors online with us today. So thank you for supporting our mission. And for those of you who would like to learn more about us, at the end of the presentation, we'll have access to our website and other social points where you can connect with us. So we are so very grateful for all of you. So, this is a little teaser before I introduce our speaker today. You may have seen a lot of exciting information in the news about Heart in a Box. We've been on KSTP Channel 5 and in the Strib, and this is not science fiction. This is really improving the outcomes for many people. So, we're going to learn more about this from Dr. Sun. And Dr. Benjamin Sun is a cardiac surgeon and researcher at Minneapolis Heart Institute Foundation and surgical director of heart failure at Minneapolis Heart Institute. He specializes in complex aortic and mitral valve surgery, heart transplantation, aortic root and aortic arch surgery, mechanical support, artificial heart, and congestive heart failure surgery. So a whole lot. But I think one of his most important roles is serving as a director on the board at the Minneapolis Heart Institute Foundation. So we really appreciate all that Dr. Sun does. Dr. Sun?
Thank you. Well, it's great to be here and to kick this off. You can hear me? I'm hoping. Okay. So we're going to talk about cardiac transplantation, past, present, and future. And many of you may have remembered some of the early days of cardiac transplantation. Is really quite fascinating. And there is a book, if you're interested in diving into it, which is called Every Second Counts: The Race to Do the First Heart Transplant. It's written by a guy named Don McCrae, who really did a fascinating job at describing the era of the 1960s that really set up the first heart transplant, and the teams that were developing the techniques and kind of racing to make it fruition. But let's rewind first and say, what really is heart failure? Heart failure is really a condition in which the heart muscle is unable to pump enough blood to support the circulation. That's really the simple part of it. We think of it as a reduction in squeeze, and that's probably the most this the easiest way to really look at it. So these are cines of a heart that on the left is a normal squeeze. You can see how it can inject the blood at an efficiency of about 65%, which means that about 65% of the blood is ejected from the heart with each squeeze. If you look at the image on the right, where the heart is starting to look more like a basketball, where it gets dilated, and you can see that the walls of the heart are not moving very hard and squeezing the blood forward. And in fact, what you are seeing there is actually the mitral valve and a bunch of blood going backwards. Though that's a relatively straightforward concept in understanding that the heart squeeze is important, it's not just that. I think there are times when the heart can be small and still able to squeeze the blood, but is stiff and can't fill the heart to get a good amount of blood forward as well. So both of those can cause congestive heart failure. And that's a huge problem for us in our society. It's still the most rapidly growing population in heart disease. Over 6 million patients, 600,000 new cases per year. It's very, very expensive to manage. The DRG is called diagnostic related group. It's what our healthcare provides and pays for this kind of this diagnosis. So when heart failure exists, it goes into various classifications, and classifications are based on symptoms. So NYHA is New York Heart Association classification of heart failure. NYHA class 1 is minimal symptoms, so you can still actively do the things that you want. NYHA class 2 is you have some limitations to what you're doing. NYHA class 3 is significant limitations, so it would be like walking to the mailbox or trying to do activities of daily living may be somewhat limited. NYHA class 4 means that you have symptoms at rest. That means you're short of breath and fatigued even at rest. So, and in that group, it has the worst prognosis. And in that group of patients, there is a 20 to 30% 2-year survival. Now, there are not many cancers that have that poor an outcome over the span of 2 years. If you see what our therapies are, and we're going to focus on transplantation versus other therapies today, but cardiac transplantation conveys about 70% 5-year survival. So when you're talking about 70 to 80% mortality in 2 years versus 70% survival in 5 years, that's kind of a big difference. So who's a transplant candidate? Well, these numbers are somewhat moving. There's a soft ceiling at the age of 70. We have pushed this up into kind of up to mid-70s. And the reason we don't go above that is because that the transplantation itself and its medications in particular that you have to take afterwards are not very kind to the body. They're very powerful medications to prevent rejection, and those medications can lead to complications, specifically increasing in diabetes, bone loss, and a higher incidence of infection, as well as unroofing or allowing other occult cancers to kind of explode. So we do prior to listing for somebody for a transplant, we do a very, very thorough workup looking for occult cancers, because obviously if we're immunosuppressing, that becomes a catastrophe. So, so we have a large number of people who may benefit from it, but once we kind of go through all these little filters to get to who ends up being listing, it's actually a much smaller number, because many patients get excluded because they have some medical issues that would make transplantation not a good option for them. That's for a different topic as to how we can address those people, but we're going to focus on cardiac transplantation. Cardiac transplantation, really the techniques of transplant were developed by these two gentlemen at Stanford. Norm Shumway and Richard Lauer are really considered in the field to be the fathers of the field. They developed the techniques where they would take a heart from one dog and move it to another dog and successfully survive this animal, develop these techniques. Many people studied their papers and went to Stanford to learn the techniques from them at the beginning, even prior to doing the first, as well as subsequent when the field started to evolve. And they certainly, Dr. Shumway has some attachments. He did some of his time at the University of Minnesota, and his daughter, Sarah Shumway, is still there, working there as a cardiac surgeon. Now, most people don't know this, but the first attempt at a heart transplant was performed in 1964 by the physician here, Dr. James Hardy, in Mississippi. And the patient was actually was a horrible case in the sense that he was very critically ill. He had amputations. He was in cardiogenic shock. He had a tracheostomy, and Dr. Hardy really wanted to save this gentleman, but there was the concept of donation really didn't exist yet during that time, and so he took a very large chimpanzee and tried to technically do this operation that had been discussed and developed. Unfortunately, the heart was not strong enough and did not support the circulation of the individual, and the patient died on the table. Not many people actually know that this actually existed, but it is a fact, and that's actually a picture of the operating room where they were trying to do this particular procedure. The first transplant that people have talked about was performed in 1967 by Christian Barnard, Dr. Barnard, and many of you may have remembered this or certainly have heard about this. Dr. Barnard did the first transplant on a patient by the name of Louis Warshansky. He had ischemic cardiomyopathy. He had multiple heart attacks in the past. The donor is this young woman that you see in the lower part of the slide by the name of Denise Darvall. She was hit by a drunk driver, and the family agreed to her donation, and he was transplanted. And that's a picture of him shortly after the operation where he was extubated. Unfortunately, he only lived for about 18 days and passed away with a combination of infection and acute rejection. Dr. Barnard performed his second, and it was actually the world's third cardiac transplant a month later, and that patient was successful and did survive 1.5 years afterwards. Dr. Barnard became the face and became a rock star overnight, and because of this achievement, and in the field of cardiac surgery, I think people felt it very important what he did, but also there was a little bit of a kind of a sigh because there were 3 or 4 other programs that were really doing a lot of the groundwork to prepare for this. Whereas though Dr. Barnard did this technically, he kind of went around the U.S. and picked up the techniques and spent some time in Dr. Shumway's lab, and kind of a lot of people felt he kind of upstaged Dr. Shumway and Dr. Kantrowitz. Dr. Kantrowitz was also doing a lot of work on cardiac transplantation as well in Maimonides in Brooklyn, and he actually did the second heart transplant on a pediatric, and the first pediatric one. It was 3 days after Dr. Barnard did his first. Dr. Kantrowitz did a transplant on an 18-day-old patient with an Epstein anomaly. The donor was an anencephalic baby, but the baby only survived for 6 hours. Dr. Kantrowitz did one more transplant and then stopped doing it and really focused on mechanical circulatory support. He passed away many years ago, but his wife and his son, whose son's actually a neurosurgeon, but his wife still have been very active in the field of mechanical circulatory support. They have a company and they have a device that is in clinical trials right now that supports the heart by putting a surgically placed balloon in the descending thoracic aorta. It's in a clinical trial right now. So that was Dr. Kantrowitz. And during this time, because of the notoriety and particularly in the success of the second transplant by Dr. Barnard, there was a rush, and there was many places really started doing this. Now, Dr. Shumway performed the 4th transplant at Stanford, but then because of the excitement worldwide, many places started doing them. But unfortunately, our understanding of cardiac transplantation was really limited to the techniques of doing it and not really the management of these patients afterwards. So because of that, the outcomes of the first 60 transplants were really quite abysmal. As you can see from this data, that of the 60, only 19 of them survived over a month. and only 7 of them survived over a year, and only 4 survived more than that. So it was a very, very sobering time, and many places just stopped doing it because though you can technically do the operation, we really weren't adding much to the patient. And the survival for some of these patients was probably not on the level of quality of life that we would find acceptable today. So many places stopped, though a few places kind of persevered and continued to try to do the science and the research and development. Of course, Dr. Shumway and his team at Stanford were really probably the biggest pillar in continuing to persevere and try to understand some of the failures that we have, particularly how to move forward with immunology. The next seminal event in terms of transplantation really occurred with the development of cyclosporin. And these 2 gentlemen, Jean Burrell and Hartman Stahlen, are credited with really developing this new approach to immunosuppression. It's a calcineurin inhibitor. It was first presented in a Congress in 1976, and it was then utilized in kidney transplants in 1977. With a successful immunosuppression control, this really opened up the field of successful solid organ transplant, having this new calcineurin inhibitor as a drug. So now today, what is we're going to move forward a little bit. I'm going to go towards today for a few things and then kind of go backwards again. But today, what does the field of transplant look like? Worldwide, there are more than 25,000 people listed for a cardiac transplantation worldwide. There are about 6,000 plus or so listed in the US. And depending on where you are and what your acuity of illness is, between 15 and 30% of the patients who are actually listed will actually not survive until a transplant is offered to them for various reasons. It also varies by country. And in the world, according to the International Society for Heart-Lung Transplant, there's only about 5,500 heart transplants performed, and about 2,500 performed in the United States. Now, there's been a modest increase over the past 2 years because there's been a new organ allocation system. I'm just going to briefly touch into that with a slide in a moment. And I am going to talk about some of these new preservation and transport systems, which we think is slowly increasing the access for cardiac transplantation. So this is a slide that gives you a sense, and in the green is what is done in North America, in yellow in Europe, and red in others. And you can see that throughout the years, there really hasn't been much of a change in total transplants performed worldwide. Though in the last 2 years, there's been an uptick in the US as well as in other places. And we think it has to do with a change in organ allocation system as well as some of these new techniques that we have to expand our donor pool. Now, when patients are ill enough so that they can get a transplant, there's 2 ways of getting them to the transplant. One of them is kind of using medical therapy to get them there, or the use of mechanical circulatory support. Medical therapy ideally is using pills first, but the people who are just on oral medications are not sick enough so that they will end up being high enough on the list to actually ever get a transplant. So what ends up happening is we start to, when the heart starts to fail, we use these medications. I call it rocket fuel, but it's these IV medications that support the heart. Now, the analogy I like to use is that you're riding a horse, and the horse is not moving fast enough for the speed that you need to go. So what the rocket fuel is basically taking out a riding crop and then whipping the horse. Now, you'll make the horse go a little faster, but you're not making the horse any stronger. In fact, you're actually making the horse weaker because you're beating it up to go the speed that it needs to do. And that's what rocket fuel does. So these dobutamines and these inotropes that we use to make the heart beat harder just to get the body in a better physical shape is actually hurting the heart. And in fact, if you're on a chronic inotrope, the data is that you have a 76% chance of not being here within 6 months, and you have a 94% chance of not lasting a year. So that gives you an idea that if you're on chronic inotrope support as a way of treating your heart failure, that you have a very short window. Okay, so that's the window that we have to either you can treat for palliation if you don't have another option. Mechanical circulatory support becomes another option. Again, a different topic for a different day. This is the window that we have to try to get somebody who is transplant eligible transplanted in this window, okay? Mechanical circulatory support is a different animal. It does require surgery. It does, but it has the ability of actually taking these medications and whipping the heart kind of as a non-entity anymore, so that you can support these patients for longer. But of course, it does require a lot more surgery. And as these wait times within the U.S. has gone up because more people are listed, and there's still, we have a shortage of, we have a disconnect. It's the number of patients who need transplants is the number of donors that we have. More and more mechanical circulatory support is performed just because we just need a longer runway to support our patients before a transplant occurs. And here's a slide that tells us that. In the green, you can see the number of hearts that are the patients that are transplanted off of mechanical circulatory support throughout the years. In the old days, we could still get more people transplanted without using mechanical circulatory support or LVADs. But now, just because the numbers are going up, then we still haven't really expanded the donor pool. A larger percentage of our patients who are transplanted are now on left ventricular assist devices or other forms of mechanical circulatory support. And that number is only going to change until we increase this donor pool, all right? Now, this is what I was talking about too. This is I wouldn't spend too much time on it. Just understand that we changed our listing from the old way of 1As, 1Bs, and 2s to a new listing in 2018 of 1, 2, 3, 4, 5, 6. Without getting into the weeds on this, just understand that we were concerned that we're going to improve access to these sicker patients, and we're going to lead to some worse outcomes in our transplants because we're only transplanting sicker and sicker patients. And in fact, one of the first papers that came out from the University of Minnesota actually showed that in 2 years, it seemed like there was a worse outcome of 15% with this new allocation. But there has been more data that has come out subsequent that has kind of refuted that, and it seems like we haven't had as dramatic a change in the outcomes over time as we initially feared, which is good. In our experience here, it looks like our outcomes have remained stable despite the fact that we've used, that we're of course part of this new system as is necessary. Now, I want to, as we're going into the transplant round, there's the idea of death. How do you define death is critically important because that gives us a definition with which to work with, and how can we decide who is alive, who is not alive, and who is the appropriate candidate for donation, right? Everybody, the traditional concept was circulatory death. Your heart stops and you check for a pulse, and if the heart stops and circulation ceases, that's death. That's been the traditional accepted method of death. I mean, everybody watches the movie, what happens. You put your finger on the carotid, he's dead, right? And in fact, many countries still use that as the only way of accepting death as the determining factor. But of course, as soon as the heart stops, the heart's not a very good organ now to use for donation, and all of the other organs will start to become less and less ideal as time goes. And certain organs are more resilient, and certain are more sensitive. But be that as it may, as soon as the circulation stops, oxygenation stops, and removal of nutrients, all that stuff stops, organs start to decompose. Brain death, on the other hand, is a different definition. It's the irreversible loss of brain function and particularly of the cortical function as well as the brainstem, which is your reflexes. And it can also occur just primarily as a loss of blood flow to the brain. Now, the clinical characteristics that has to exist for brain death are the three that I listed here, which is coma, you're not responsive, absence of brainstem reflexes, and there are a few of them like corneal stimulation or peripheral reflexes, they go away, and apnea, meaning you don't have the drive, the central drive to breathe. Okay, so those three clinical characteristics exist for brain death. Brain death was not accepted until very recently. And this is and with all the bad things that people have said about Christiaan Barnard for his early cardiac transplantation and his notoriety, he was a very important person in helping define the concept of brain death. All right, he pushed that within his country and got his country to accept it, and it was used as an example in other places to try to move the field forward with this concept. Now, not many people know this, but there was a lawsuit for this concept in the United States against Dick Lauer in Virginia. So there was a trial where the estate of a Mr. Bruce Tucker, who was donated for a heart transplant, used his heart for a patient, that Dr. Lauer, the surgeon, was sued for wrongful death in this patient. It's a complicated story, but at the beginning of I'm going to describe the story a little bit because it's really quite interesting. But at the onset of the trial, the judge in the trial, that it was court's duty to apply and interpret the existing Virginia law on when death occurs. And this definition stated, death is a total stoppage of the circulation of the blood and a cessation of the animal and vital functions consequent thereto, such as respiration and pulsation. And he said to adopt the legal concept of death, and as that was stated, and reject the defendant's attempts to develop the medical concept of neurologic death as establishing a rule of law. In other words, he was saying, we have a definition, you as a jury have to stick with that definition and ignore the fact that the defendants are trying to create this new definition of brain death. That's what he said. So when they said that, this was descriptions in the courtroom, the announcement quickly silenced the courtroom since it virtually assured that the jury would be compelled to reach a verdict averse to the accused physicians, i.e. they thought the physicians were going to be done. In fact, there was a phone call between Dr. Lauer and one of his colleagues that said, I'm going to go to jail because I'm going to be convicted for manslaughter or something. This was an interesting story because Mr. Tucker was an estranged, he was a 56-year-old African-American gentleman whom had been estranged from his wife and daughter, but was hanging out with some buddies and had something to drink, and he slipped and he banged his head. And his friends called an ambulance for him, and he said, no, I'm fine. And he walked away. The ambulance came, and they finally found him, and they took him to the hospital, at which point he passed out. He had a head bleed, so they did a cranium on him emergently, and a day and a half later was declared brain dead. The problem was they didn't know who to contact as a family member. So they called the police, and they tried to identify next of kin, but never did. The interesting thing is at the time it was really quite short, so it wasn't really clear how hard they really looked, to be frank. Apparently his girlfriend was actually walking around the hospital looking for him. They never found her, and they never hooked the two. And he apparently in his pocket had a business card with his brother's phone number and address, which is only 15 blocks away from the hospital, which they never identified nor never called him. So now they have a John Doe who is brain dead, and the hospital people met together and decided he was by clinical definition was brain dead. So that was not the issue. But there was never consent. But the hospital said, okay, he's dead. We don't know who his family is. We tried to, in good faith to contact the family, so you can use him. So they did a heart transplant. Well, that's what the suit came from, because they maybe not have worked as hard as they should have. Anyway, yeah, so what happened was after, as they went and presented their cases, when the judge, and at the end, charged the jury, he said this: you shall determine the time of death, in this case by using the following definition of death, of the nature of death. Death is cessation of life. It is the ceasing to exist. Under the law, death is not continuing but occurs at a precise time, right? They talk about the circulation. But you may consider the following elements, and among them the time of complete and irreversible loss of function of the brain. So the judge changed his mind and gave the instruction to the jury, you can consider this if you like. Ignore what I said before. And so this is the first time, so they got acquitted. This is the first time in '72 that it was that brain death became, at least in the legal books, the first option that could occur. And then The Uniform Determination of Death Act in 1980 basically accepted this as a form of death. Okay, so it was 1980 that in the U.S. we accepted officially brain death as death. So I talked about this, we talked about this. But that opened the door for at least donor by brain death. So DBD is what is commonly used today. So we wait for brain death, and then we do the donation. And what are the criteria that we're looking for? Well, age is certainly a criteria. The younger, the better. If you're old, particularly for the hearts, we kind of have a, yes, we can go into the 50s historically, but we've not gone much higher into the mid-50s or upper 50s. And I'll describe why. This number is going to change. The mechanism of death is important. Obviously, chest trauma is not an ideal thing, but isolated brain injuries and whatnot are important. Medical history of cardiovascular issues are important because it guides us as what other diagnostic studies besides an echo to look at function are important. Patient size is important because we really have to size the patient's heart to the recipient's heart. You can oversize the heart a little bit and that'll be fine. You can't undersize the heart because these hearts, unless it's a child's heart, doesn't really grow. And I couldn't put a child's heart into a 6'5" person. It just wouldn't grow fast. I mean, you won't have the stimulus to grow fast enough, and it just would be, it would be like a hummingbird. It was trying to be too fast. It just would not work. So sizing from a donor recipient is important. The echo, of course, we just need to look at cardiac function. And then we have to coordinate because all of these, I hate to break them down to the organs, but the body likes to be in a normal homeostasis. But as we're preserving these organs for transport, we like to get a little running start. And so each of them likes something a little bit different. And so the coordinator has an extremely challenging job dealing with all of us, though by and large, we're much better today than it was 20 years ago when I started doing this, where we were fighting all the time. Anyway, there are different ways of preserving it, which is not important, but just understand the traditional way of doing a heart transplant is that you've seen on television, you go to the institution, everybody is calm, you put the heart on ice, you preserve it with a preservative, and then you get on an airplane, right? Meanwhile, the heart's just sitting in an ice bucket, and you're taking a nap on the way back. There's not much to do. And then you put the heart in, and God willing, everything wakes up, and you're okay. The surgical timing is important. We want to have the heart out and the heart in within 4 hours. Between 4, 5, and 6 hours, there's a measurable decrement in the cardiac function over time just because our preservation solutions are limited. We don't have that with a liver or the kidneys. You have 48 hours. So those guys, you can actually send those organs on commercial flights, which is sometimes do with a courier, because you don't have to rush back. You can get them back within 48 hours and you still have 24 hours and still have plenty of time. We don't. We're coordinated. That's why we're always doing it whenever we get it. We're doing it in the middle of the night often. So one big downside of doing heart transplants, which I love doing, is that it's almost always in the middle of the night. So as we talked about the donation after, there's an upside. The heart is still beating. Procurement is a very stable. It's almost like taking an elective patient to the operating room because they're very stable. We can plan this. They often do it at the end of the day because they usually wait until all the elective cases for the patients in that hospital who need surgery to be done, and then we kind of get stuck on the end, which is appropriate. I mean, I'm not, but that's why it's always in the middle of the night. The operating room is very relaxed and methodical. The technique is very simple. Clamp, perfuse, cut it out. Stick it on ice, go to sleep. The downside is it has to be a perfect heart. So we are not using all the hearts that we probably could because we're afraid of when we put it on ice, we have no idea what's going on with it. And if the heart's not a good heart, when it wakes up, we're kind of stuck with it, right? And that's not a good place. So because of that, we typically looking for the perfect heart every time, all right? And that means we're probably not using every heart that probably is usable because we look for things that maybe won't make a difference, but we'll say no. In reality, it probably didn't make a difference, but we're just afraid that we're going to have a bad outcome. And appropriate so. I think you want us to be like that because if I'm taking your heart out and I'm putting a new one in, that heart better be pretty darn good, or perfect, right? I mean, that's what you would want. That's what that's our approach. So, so we also have a limited window of travel. So we have a travel window that you have to, and when we have weather issues, it messes things up. We have a big headwind, and the heart's coming back in a big headwind. That changes things. It changes our timing, and it can lead to bad outcomes. The technical aspects of it I really want to go into because there are a few ways of doing this, but basically we cut it out, we sew it back together, and it sounds trite, but it's surprisingly easy technically to do this. I'm sewing 4 big things together. Just doesn't take very long. This is the way that we typically do it. It's called bicaval. It's much cleaner. But again, on what we call a if you didn't have previous surgery and we weren't doing anything fancy, this operation, 2 hours, 15 minutes, skin to skin. If you're a reoperation or I have to take out an LVAD, 4.5 hours, maybe 5 hours. Sometimes it takes longer, but that's typically the timing for it. And the survival is pretty reasonable. If you look at it in the blue, that's where the pediatric survival is, which is better than if you look in the green, which is adults. So in the adults, if you look at it in terms of years, you have about a 50%, 10-year survival rate thereabouts. So this is a good therapy for when you're looking at where we are before. If you're 25 years old, maybe we should push this off as far as we can. Again, different topic, different time. So we can optimize our long-term survival. But for, kind of the sweet spot, I think is kind of the 60, 65, 70 sweet spot for heart transplant. Most people have a very good quality of life afterwards. If you were working beforehand, you're often working afterwards. If you're retired beforehand, you're usually retired afterwards. So let's talk about what is happening today, what's new today about this, and what can we do to expand this donor pool, which is what we think is important. And the relatively new innovation, it's called the Organ Care System, which what it does is instead of taking the heart out now putting it on ice, we're taking the heart out and we're putting it on a system that actually is pumping blood into the heart and washing out some of the impurities, doing some of the oxygenation and to the heart, and we can give medications to the heart, and we can also measure things within the heart that give us a sense of, is this heart happy? Is this heart not happy? And there are some technical challenges for it, because now instead of just cutting it out and throwing it on ice, we have to cut it out, and then we have to put some attachments to it. Then we have to hook it up to this machine. Not only do we have to hook it up to the machine, but now we have to monitor what is going on with the heart. So we have to be checking bloods, we're checking pressures, we're adjusting medications. We're running an ICU now with this heart for the entire trip back. So it is not easy to do, and some of the places that have tried to do this have failed because they have not had the right individuals with the right sense of obsessive compulsiveness on the transport to manage these hearts. And this is what it looks like. So there is a console that obviously takes up a little bit of space that has to go on the airplane. And this is the disposable that you see that is basically gets hooked up into here and connects everything. This is a fancy pump. The heart is actually going to sit in this area right up here where we hook it all up. Blood is going to be flowing through some of these tubes. There are some sensors in this area. There's a reservoir that has the blood in there, and it oxygenates and perfuses and adds pressure to the heart as it's doing it. We have medications that end up being hung down over here that are controlled remotely, so we can adjust medications that are delivered into the heart. And this monitoring system here monitors the heart and monitors pressure as we're doing this. And there are areas where we can draw blood off and test blood to assess what the heart is. Now we have a tool that we can not only assess the heart for the entire trip, and we can potentially take hearts that we typically would not and see if we could actually make them good transplant hearts, because we're managing them throughout. We can actually see if it's getting better, which we're hoping, stable, or worse. And we can also intervene if we think that there is something, if it's starting to go in the wrong direction, we can intervene, and then we can see if it gets better. And if it does, then we can still use it. So now we have a different tool. And this is what it looks like. Some of you have seen this before, but this is what it looks like because the heart is beating and the blood gets recirculated into these tubes. We can draw off lab values. There's medications being run into this thing. And besides just looking at it, we actually are measuring metabolic issues that are going on. And that is changing, has a potential to change what we do. This is not FDA approved yet. This is in FDA panel right now for one indication. And that indication, which is in a study that we've been blessed to be part of with the foundation, is called the EXPAND study. And with the EXPAND studies, and don't read this. Those are essentially, I just want to show it to you with the idea that these are characteristics of hearts that are typically not ideal, but probably are still within the realm of probably usable. We just have not used them because we've been afraid of what could happen when it's sitting on ice and not knowing about it. So now we have a way of doing this. And what we've done is these characteristics, which are subideal, we put them on on the device. The device is able to resuscitate these heart or give us enough information to say, yeah, this heart's pretty good. We should use it. And we've been using it. And it's a national study. And we've been very happy with our interaction with the hearts on this study. And we've utilized virtually every heart that we've gone out for this, and the hearts have done very, very well. So because of that it's in panel right now for the FDA. We're hoping that it gets FDA approved for this therapy within the next month or two, but that would be one indication that we hope it gets approved for. Now, the next potential adventure, or the next adventure that we've are going into, is the concept of donor after circulatory death. Now, remember we talked before about brain death. Now, the study right now and the organ care system is being utilized in these donors that are brain dead donors. So again, we can electively go there. We can, the heart's still beating. We still take these hearts from the beating patient, even though they had these, unfavorable characteristics to put on the system and use it for transplant. Donor after circulatory death is a different animal. That has been going on for several years now, and they utilize kidneys and livers for it. But how that works is that these patients have catastrophic brain injuries, but they're not legally brain dead. They don't fit the specific criteria that defines brain death, but they have enough a catastrophic brain injury that they're not going to have a long, meaningful life afterwards. And that's been determined by multiple factors. Now, what happens is that for those people, they're actually just being supported by a ventilator. And so the way of doing, so for those patients, they can be extubated. So the breathing tube is taken out. And then if the heart, and if they're not breathing because they're apneic, the heart will stop. If the heart stops, then they can go, so now circulatory death, they can go and procure the organs for the liver and the kidneys. Now, this group has not been a good option for a heart because the heart has to get ischemic, it's no oxygen, and it actually stops because it's unhappy. Now, to take that and try to put it on ice and do a regular donation nobody would ever do it. But with this system, you can now take this heart that has already stopped and said, I'm really not good, put it on the system, resuscitate it, start it up again, give it some oxygen, kind of let it chill out for a little bit, and see if it's going to be a good heart. Because some of these are good hearts until we've taken the oxygen away from them. There are some specific characteristics which I won't go into the details with, but that's the kind of the general concepts of donation after circulatory death. Now, this is a totally different exercise because the timing is critical. You have to go so fast as you can in these circumstances, because every minute where all the organs are not perfused and are slowly decompensating is important. And the heart and the liver in particular are extremely sensitive to every minute. And so this is a controlled chaos in these procurements to try to get these organs protected and procured. And then it's a lot of work to resuscitate and manage these hearts to see if it's going to be utilized. The brave two first sites that did this was St. Vincent's Hospital in Sydney, Australia, and the Royal Papworth Hospital in the UK. They published their first, they presented these at several meetings that we were all there and like pinned because we were so excited that they were, one, they had the intestinal fortitude to do it, and number two, that they were able to get it to successfully work because they were the brave ones to start this and allowing the rest of us to ride on their shoulders. But they were successful in using these hearts. There are some blips with it there in the sense that you have to use them a little bit more support. You have to use a little bit more mechanical support early after the transplant. But the 1-year survival essentially was the same as if we did it the old way. So that got everybody excited that, yeah, we should move in. And so that has moved into the United States. We've been blessed to be part of that study. And we've done 2 of our patients with donor after cardiac death. And we're done. We did our first on January 12th, 71-year-old gentleman who was on an LVAD and underwent our first DCD. He was on ECMO, extracorporeal membrane oxygenation, or a heart-lung machine for about 48 hours afterwards to kind of allow the heart to really recover more. But he had full recovery of his donated heart, and his breathing tube was taken out. And he went to rehab and has been home for a while now and done very, very well. He was the first to be done in Minnesota. This was our second one. This is actually the heart that we use. He was a 57-year-old gentleman, blood group O, also supported by an LVAD. And this is the heart that, as he came back, we were so happy with the way this heart looked. We put this heart in, and this is him the same day. I had just finished operating on him 4 hours earlier that morning, and he's sitting there smiling, with his breathing tube out with Dr. Runowitz 4 hours later, and he was home in less than a week. So these are the active sites that are doing donor after cardiac death in the U.S. The data right now, we don't know what the aggregate data is, but I can tell you our experience has been very positive, and others must be because the numbers are growing, and they're places are excited. If they were unexcited about it, they wouldn't be doing it, and they're doing lots of them. And so how will it affect us? Well, I think what it does is has a potential to totally change what organ procurement may look like down the road. If this all works, we are, going to expand our pool. We already are going to start to expand our pool because we're taking hearts that we would consider not perfect, and we're finding that we're wasting a lot of those hearts. Most of those hearts are still, good options for us because we have more information to tell us, yeah, these are good options, all right? So that's going to change. Number two, when we start to, when hopefully we get approval for donor after circulatory death, that's going to, add another level of patients. So we estimate the expand criteria to add probably another 20%, maybe more, to our donor pool. Right now, 20% of a region's organ procurement area is doing donor after circulatory death, and that number is just probably not even a half of what we think that number should be in a year or two, because that number is actually growing very fast. So that, probably half of those, if not more, may be candidates for this. So again, another incremental and maybe a larger incremental jump in organ opportunities, availabilities for our patients. So if we actually increase the number of donors, our wait times are going to go down. The complications, the death rate of people waiting are going to go down. We may decide to change the criteria of whom as a candidate. I mean, we may relax that a little bit more. There are other pressures onto the heart transplant field now with mechanical circulatory support as they get better and better as well. But these are other options that we can have for our patients now that may change that. And what I think is actually going to probably happen is that we may end up regionalizing organ procurement areas. So we may have centers where we actually can do this and do this well, because not everybody can do it well. And the company recognizes that. It recognizes that it's very complicated to get things going up front. And so they're hiring more people and also contracting individuals to help out with this, to get more sites, to maybe take some of that burden off of the local site and put it into a kind of a regional setup so that the organ procurement can be done by a regional team and then optimized and then distributed out. So there are various things that may occur that will that has the potential, again, maybe I'm getting a little ahead of myself, to kind of alter how organ procurement is performed, at least certainly for hearts in some of these. So there are other research that are going on that are very, very important, that is unclear how they're going to play into this. Transplant tolerance is an idea of how can we get your body to accept this heart better, or this organ better, without giving you as much medications, or reduce the medications. So part of that is like, do we do a bone marrow transplant? So we take the donor's bone marrow and then do a transplant of the bone marrow at the same time we do in the organ. So you have some white blood cells that kind of recognize both and say that, this is not so foreign. It's a complex issue of creating chimerism, and I don't want to get into that because it's very scientific, it's very complicated, and I don't understand all of it either. But that is being worked on, and with the goal of trying to reduce the amount of immunosuppression you have. Xenotransplantation is also getting a lot of buzz recently. They've talked about they're taking some pigs, and they are altering the genes of the pigs right now, so they don't look like pigs, at least on a protein level, and they look more like humans, so that you can take those and put them. And that is, initially it was like peeling an onion. You keep doing that, and there's another layer. But they've made some big changes within the last 2 years or so with this. They knocked out these 3 carbohydrate antigens called a triple knockout, TKO, and it's made a big difference. So they're taking these pig hearts and transplanting them into monkeys and not giving them any immunosuppression, and they've gotten some of these monkeys to survive with no immunosuppression, taking a pig heart into a monkey. So it's a little scary for multiple reasons. In particular, now with COVID and all of the idea of a transmission of some new bug that may come from a pig to a monkey to a person or whatever. Yeah, so we'll see how that goes. I think there's a lot of hurdles that xenotransplantation needs to overcome that before it becomes a legitimate option for us. And the idea of tissue engineering is also very hot. There are 2 areas that people are looking at in terms of tissue engineering. Number one, growing a heart in a biologic incubator, and that uses some level of 3D printing to print certain kinds of scaffolding, and then adding stem cells to it so that the stem cells can differentiate and then grow tissue in a biologic reactor. So there are many labs that are working on variations of that, because there are labs that are just working on the 3D printing component of the scaffolding, and then there are others that are working on the transplantation component of it. Let's just say that there's so much going on there, it's really hard to try to stay up on all that. But it's fascinating to me, that's why I read about it. But they first are growing blood vessels, and then they can add other things on top of that in layers. So that's exciting, that's coming. It's probably a good 10 years before that's gonna be really useful, maybe sooner. There's one other technology that's really fascinating, which is the idea of taking an organ from, let's say, a pig, and then decellularizing it. So you basically treat it with a detergent, and you take all the cells out of it. So when you take all the cells out of it, you basically just have a scaffolding of a heart or a liver or a kidney. And it just looks like it. It looks like a clear heart, kidney. It doesn't beat or anything. But then what they do is they put it into a bioreactor where they put stem cells or attach it to another, and sew it into an animal. And so the animal is perfusing it with blood, and the stem cells kind of lay in there. And then eventually the stem cells understand, based on the architecture of the decellularized structure, what is supposed to be, so it differentiates into it. And so there's a famous paper where I'm blanking on her name right now. Anyway, she took a heart and decellularized it, and then put it in this bioreactor with blood, and this heart started beating in about like 3 months. Now, it wasn't beating strong enough that was going to support anything, but just that the proof of concept existed is fascinating. Now, again, that's TBD, but very, very exciting down the road. So if I were to look at a crystal ball, my last slide, I do think that improved mechanical hearts or ventricular assist devices will still dominate the heart failure area. We didn't go into why that is, but they're just easy to come off the shelves. The innovation for that is very fast. There's no immunosuppression to it. I can put it into cancer patients, and I'm not wasting a life, so to speak, by taking somebody else's organ into it. This comes off the shelf. But again, we can talk about that at some other point in another talk. OCS, as I talked about, the procurement system will likely redraw the field. I don't want to restate the things that I've talked about, but it will increase the donor pool, it will shorten wait times, and will likely expand the field. The immune modulation, immunology takes a lot longer in terms of understanding its long-term effects on us down the road, and so those will be incremental things. I think the idea of chimerism and transplantation is probably still a bit off. In tissue engineering, 5-10 years. Xenotransplantation is a famous quote. I don't know who said this, but I use it, and I need to find out who said this, is that it is the future of cardiac transplantation and always will be. I.e., I don't think we'll ever get there. That's my opinion. Hopefully I'm wrong, but so that's cardiac transplantation, past, present, or future, and I'll take some questions.
Well, thank you very much, Dr. Sun, for that excellent presentation. We really appreciate your time. As he mentioned that Q&A is open at this time. Thank you to those folks who did submit questions during registration. And Dr. Sun, I believe we placed a copy of those questions on your podium. But if you'd like to submit an additional question, we have instructions here on the screen. But what you're going to do is you're going to drag your cursor to the bottom of the Zoom screen. If you're on your phone, you can go ahead and just tap your screen and find that Q&A pod. You can send questions anonymously, so go ahead and send those, and we will try to get to as many as we can. Dr. Sun, if you want to go ahead with the preloaded questions, that would be great.
Yeah, so one of the questions which I didn't address was, are heart transplant used in patients that have been diagnosed with pulmonary hypertension related to, and they describe a procedure. So pulmonary hypertension, which is high blood pressure in the lungs, is a relative contraindication to heart transplants if it's untreated. Now, why is that? Well, the heart has two sides. There's a left side and the right side. The left side really is the heart, is the side of the heart that pumps blood to the rest of the body, and that's what gives you your blood pressure per se. That's the strong part. Then there's the right side of the heart, which basically just has to pump the blood through the lungs, and that's a low pressure system. And because the lungs are it's a high capacitance, low pressure system, and so if you have high pressures in your lungs, a transplanted heart, which is not used to beating against those high pressures, will fail. Okay, because it's just not used to stuff. If I give you, if you gave me 50-pound dumbbells and told me to do curls, I couldn't do it. I could do 20s and maybe 30, but that's it. And that's the same concept. But there are things we can do to bring those pressures down. And by bringing those pressures down is the goal for many of the therapies that we do for people who have high pulmonary vascular resistance. Left ventricular assist devices are one of the most powerful ways of doing it because it unloads the left-sided heart pressures. The most common cause of high pulmonary vascular resistance or right-sided pressures is left-sided pressure, congestion. So if you reduce that with medications or with mechanical ways of doing them, like mechanical support, over time those pressures in the right heart can go down. And when they go down, then all of a sudden they become good transplant candidates. And we do that all the time with high PA pressures. Somebody asked about minimally invasive heart transplants. There's no such thing. Minimally invasive, the heart transplant is maximally invasive. We need big incisions. There's just no way to do it. It doesn't exist. And it won't likely in the foreseeable future. Our research that we do, somebody asked, where can people stay up to date with the research that you and our team doing? I think the MHIF website gives you an idea of what studies are ongoing, and so you can get a sense of what we're doing. Obviously, when research is ongoing, we're hopeful, but we have no idea what the outcomes are going to be until the study is done and it's appropriately adjudicated. So, we'll give you snippets of things as we can and we're allowed to do with our various studies. But until things are really, kind of buttoned up, it would probably be wrong to talk about it too much because we don't know if things are going to work out for the better or for the worse when a study exists. What am I most excited about regarding the future of cardiac transplantation? for today, the OCS system, which has the potential to expand the donor pool and change the number of hearts that are available and shorten people's wait times, is the most exciting thing that I see today. Most of this other stuff that we've talked about the future still have a lot of things to go before they become transformative. Yeah.
We've got a few online questions. If you could just take a few more, that would be great. So the first question is, what is the most significant thing our community could do to increase the number of hearts available with the transplant program at MHIF? And also a follow-up question, do you see any challenges with donor hearts post-COVID-19?
So for the first part of the question is engage in LifeSource. LifeSource is our regional organ procurement organization. I am a member of the clinical policy board it's a wonderful organization that does that is the bones of the operations of getting these organs allocated within our system. They also do a lot of work with outreach and education to get communities involved and to try to address any concerns, myths, or otherwise that are out there regarding organ donation. It's a wonderful group of people. They're hardworking. Sue Gunderson is a CEO, and she created this group. She is just a spectacular individual, hardworking, and I would suggest engaging with LifeSource. The second part of the question was how has COVID affected us, and we tracked the whole nation was tracking how COVID was going to affect transplantation, and early on, of course, there was a big dip, as we expected, because the hospitals were focused on treating our COVID patients and making sure we had the right infrastructure for that. Traveling for organ, even assessment of whether or not a patient was appropriate for donation was just stopped. And then we didn't have rapid tests to confirm it. We didn't know how many of these patients who had potential were COVID positive. So early on, there was as one expected. And as we got more data and more ways of testing for some of these patients to see if they had COVID or not, that changed. As some of people became more comfortable traveling and doing assessments, they picked up. And as of the last year, the cadence, so our actual loss in terms of total organs, organ procurement, organ donation over the year was reduced. I think it was region dependent. In our region, our numbers were not too far off what they were the year before. Now, that totally subtracted what we thought our growth might be. So we were still a little bit below our year before. So our growth was gone, and then we lost a little bit. But thankfully, it wasn't a catastrophic drop. Every region in the country bore a burden that was a little bit different. I think the Northeast took the biggest hit for reasons because they were the first and hit so hard with COVID early on that they had the biggest hit. So yeah, great question. But it's bounced back, and we are right now we are ahead of where we were last year.
Wow, that's incredible. Thank you very much for that. I think, we've got a ton of questions in the Q&A pod. Unfortunately, we won't be able to get to all of them, but I think a good one to end off on would be, how do you think your program will be impacted after the organ care system receives FDA approval?
Yeah, I think our wait times are going to drop, which is great. And so it just becomes kind of loading the truck. So our goal, so is the throughput will improve, which is great. And so it's about how fast can we load the truck. And then the next discussion is at what point ideally we want to do less critically ill people. So as we go lower down on that scale, the acuity scale, which I showed you, so the ones with the sickest and the sixes were less sick, the patients, the less sick that they going into a heart transplant, the better they do on the other end. We have lots of data on that. So what will end up happening is, what we hope is that we'll get people into the queue before they're critically ill, but ill enough. And then when they go through the pathway, the recovery will be quicker and their outcomes hopefully will be better.
Excellent. Well, thank you very much. I think that's all the time we have for Q&A, but do you have any words for our audience before we sign off here?
You know, maybe every era is great. I'm just so excited about where we're going with this field. I feel blessed to be part of this organization, to be part of this research foundation that allows us to participate in these kinds of innovative and fun studies.
Absolutely. Well, thank you very much, Dr. Sun, and thank you, Chris Fortman, for your time today as well. Thank you, folks, for joining us today. Please know that as you exit today's webinar, you will be auto-redirected to a survey. If you could please fill out that survey, as it does help us adapt these talks for future presentations. So thank you again to everyone, and have a great day.